What is a heart attack? What is a cardiac?
Our heart, basically, all of us will have in normal 3 vessels. When there is a sudden blockage in any one of the vessel, it is called as heart attack. Your heart beats very fast, it can go for a cardiac arrest. Your heart beats very slow, it can go for a cardiac arrest. In this AI era, everybody wants to diagnose, everybody wants my job. I did 15 years of education to sit here.
Thin outside, fat inside. Some people think thin people are very healthy, they'll never get a cardiac problem.
Thick and thin has nothing to do with it at all.
What are the silent symptoms which people nominally ignore?
See, when the symptom is truly silent, they are definitely going to ignore. A block is something like you add money to your savings account every day, every month. 5, 10, 5, 10, 1, 2, 3. An attack is not like, it's like a lottery. 100 rupees falls in your account today.
How much does stress play a role for heart-related problems?
Stress and lack of sleep. That is the worst thing you can do for your body.
Women don't have heart-related problems when they're 45, 50. Is it true?
Men are at more risk compared to women. Okay. The more important point is, women have worse.
The typical distinction for us to make, whether it's actually a heart attack or acidity problem.
It's not.
Dr. Aravind, welcome to the Greater Than podcast.
Thank you.
I am so looking forward for this conversation. And I'm going to straight away start. Healthy people who eat well, exercise regularly, but suddenly have a massive cardiac arrest and die. Can you tell me why?
Okay. See, you'll have to look at in different decades of what happens. Okay. So when you ask this question, I assume that you're asking about a healthy 35 or around 40-year-old person.
Yeah, 30, 35, 40, young, according to me.
Okay. So there is a shift. Okay. So what we have been seeing in things happening in 50s, what was happening a decade or before that, now we have seen a decade before the events are happening. So the events in 40s have drastically increased. So let me put this number. People whom I put stents in acute heart attacks, the number is roughly about 25 to 30% is all people between less than 50 years of age. Okay. That is how the numbers have drastically gone up. Now, when you take it less than 40%, it is roughly 20-25% of the people are between less than 40 years. That is between 35 to 40 years. At least in last week, I've done 2 patients who were less than 40 years.
Okay.
So that is how the numbers are going in. Okay. The reason for it, we can, there has been, for starting from 2000, there has been a constant increase in this trend of heart attacks that is happening. I would attribute predominantly to the lifestyle changes that have been happening. There are a lot of lifestyle changes that is happening here. We are eating a lot of junk foods that I would attribute to, and there is people who are not. The mobility in them has drastically gone down now. They are not walking. They are not. The physical labor has drastically gone down now. I would say sitting is a new smoking that is adding. That is the cherry on the cake. That I would
more
say.
than smoking and drinking, sitting
sitting is also adding. So lack of physical activity, erratic eating, erratic sleep patterns, they've all compounded to this 1 decade. I would say maybe they're biologically in 40s, their cardiac age should be in 50s.
So the heart age is actually 50, maybe the biological is 50.
Exactly.
Now tell me the other thing, right? Before I go there, I want to give you statistics which kind of shook me. WHO says that 4.5 million cardiovascular deaths in India. 1 in 3 people who die in India is because of a cardiovascular death. That's how bad the data is. Now, with the data in mind, I recently read a 19-year-old boy playing cricket, hit a 6. This video went very viral. Hit a 6, fell down and died.
Okay.
19 years old.
Okay. See, here, so this is where age plays a role. People think when somebody dies of sudden death, that is always heart attack. Okay. Other than heart attack, there are many other reasons for cardiac arrest. Okay. Especially in younger individuals, we should think of a lot of other things. There is a condition called arrhythmogenic right ventricular dysplasia. There is a condition called hypertrophic cardiomyopathy. And there are lot of long QT syndrome, short QT syndromes, which all can cause ventricular arrhythmias and that can land up in cardiac arrest. Let me simplify it for you. When somebody has an heart attack, why does that person die? When somebody has an heart attack, when we say it is cardiac arrest, it is predominantly that heart is not pumping is one thing. The other thing, why that heart is not pumping means either the heart pumps at a very faster rate. It goes more than 200 and it is not able to send blood to any other organs, including its own muscles. So the patient is going for a cardiac arrest. Okay. So similarly, when an electrical misfire happens, the heartbeats can go more than 250 and people can develop a cardiac arrest and die. So there can be a lot of other reasons than heart attack itself for cardiac arrest to happen. And people whom we should screen this is one, when there is a strong family history of sudden cardiac deaths. In those families, there are certain conditions that needs to be screened and they should be evaluated. Whenever there is a sudden cardiac death, an unexplained death that happens at home, definitely a postmortem needs to be done and it needs to be found out what is the cause of death, and if it is a thing that can run in families, that should be identified and that should be prevented.
So what you're saying, doctor, ideally is, because normally in our culture, if somebody dies of a heart attack, we say heart attack and we cremate or bury because it's a heart attack, because we have made it very normal that heart attack happens. What you're ideally saying is, if a heart attack happens, we need to understand why the heart attack has happened.
Why that cardiac arrest has happened.
Yeah.
So the terminology.
What's the difference? Yeah, first tell me that. What is a heart attack? What is a cardiac?
Okay. So an heart attack is, our heart is a muscle. That muscle needs blood. Okay. That blood is only going to give the essential oxygen and nutrients for it to pump. So our heart, basically all of us will have in normal 3 vessels. Some people will have 4 vessels that supply the heart. Okay. Heart has 4 chambers. The left ventricle is the last chamber from which the blood is pumped through the entire body. It has a valve called aortic valve. Right out of it is the coronary vessels. That is the vessel that supplies the own heart itself. If there is a problem in that valve, the very own heart itself won't get enough blood. Okay. So now we have established the anatomy. In these 3 blood vessels, when there is a sudden blockage in any one of the vessel, it is called as heart attack. Okay. When a vessel that is supplying the heart muscle that has a blockage, that has a sudden 100% occlusion, that means that territory is not getting enough amount of blood. So that territory won't be able to pump. So that cut of blood is what will cause you chest pain. Okay. So that is when you get an heart attack and you go get treated. So people do an angiogram. Angiogram is nothing but seeing these vessels in an X-ray.
Okay, let me try it on. Heart attack is basically vessels pumping. When there's a block, when blood is not pumped and heart is not functioning properly.
When the vessel is blocked, it is heart attack. Cardiac arrest is something. If this heart attack is massive, okay, it generally happens in massive heart attacks. You get a cardiac arrest. That means your heart itself is not pumping. Okay, or because of this 100% occlusion, there is an electrical abnormality that has happened. Your heart is beating very fast. So your heart beats very fast, it can go for a cardiac arrest. Your heart beats very slow, less than 40 or less than 30, it can go for a cardiac arrest. Either extremes will cause cardiac arrest.
Okay, the distinction is heart attack is vessel not going and up, it's not properly pumping. Cardiac arrest is either it's pumping too fast or too less.
Low as a complication of this heart attack.
So death normally happens when you have a cardiac arrest.
Any heart attack related death is because of cardiac arrest.
Cardiac arrest. Okay. So now you have established that. You said for a 19-year-old, it could be a signal problem. It could be n number of problems.
It can be a valvular problem. I said the valve obstruction that can happen. Even a valve obstruction can cause death. So those things needs to be identified. A proper screening needs to be done.
Okay. Before we go to screening, what are the silent symptoms which people normally ignore?
Okay.
According to your...
when the symptom is truly silent, they are definitely going to ignore.
Yeah.
Okay. So true silent it is predominantly in diabetic people and in women. Okay. It is when I would rather say it as atypical symptoms. Atypical symptoms are symptoms that you think it could be because of some other reason this particular symptom was there. Say somebody has a neck pain. Say somebody has a jaw pain, okay, or a burning sensation in the chest. That would be a classical example. Yes. Okay, somebody says, I have burning sensation here. Our immediate thought process would be always it is gastritis.
Acidity, gas. Yeah,
exactly. So heart attack can present with gastritis also.
Okay.
Okay. So gastritis-like symptom. Okay. So this atypical symptom is very common in diabetic people and in female patients. Okay. So this sudden retrosternal burning sensation that they get, which is not getting relieved after some amount of time. It is that is one of the atypical symptoms that you predominantly miss. Jaw pain is another atypical symptom that gets missed. Okay. Some very rarely people can even have it as in back pain as in heart attack as in presenting symptom. So the problem here in this atypical symptoms is when the symptoms persist for more than 20 minutes to half an hour, in spite of your conservative treatment, whatever you are trying to take, it is better always to go meet a physician, especially when you have comorbids, when you are a diabetic patient, or when you are a hypertensive, when you are a dyslipidemic patient, or if there is a strong family history of heart disease and other elements. When you have these atypical symptoms, rather than taking medications or self-medicating yourself, it is always ideal to have a physician to see, to rule out if there is any underlying problem or not.
Okay. So the typical distinction for us to make, whether it's actually a heart attack or acidity problem,
it's not your job.
Okay. First, we can't make the distinction.
Yes. I'll tell you, the overlap of symptoms is sometimes very, 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 very significant that even a trained medical professional can miss it. Okay. So that is why we have layers of investigations. Okay. When somebody comes to me, say with gastritis, they say I have a burning sensation in the chest, and they come to my ER. What all things I would do? I would do an ECG, I would do an echo, I would have a complete their history and physical examination of their family history, and I would also do something called troponin. Okay, this troponin is what is a muscle marker. When the heart muscle gets damaged, this muscle marker goes elevated. In fact, I do something called rule in and rule out. When there is clinical suspicion is high, when their symptoms is very particular, but the ECG echo is not very convincing of an heart attack, I would even repeat the troponin twice. My general principle is I always repeat it twice, so that I have one baseline value, I have a second value, and I rule out it is a heart attack. Okay, my job here is to say for sure you don't have a heart attack and you go back home.
Is it a blood test?
This troponin is a blood test.
Troponin is a blood test.
Yes. Okay. So, for people to differentiate this symptom at home is a very, 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 very tough job.
So, we're not going to answer that question. We are not going to say, please don't differentiate, because it's very difficult.
It's very difficult.
So, what you're saying, doctor, ideally is if it's there for more than 20 minutes.
If the symptom is persistent and it is there for more than 20 minutes and you feel it is an unusual symptom that you have never experienced in your life before, don't hesitate.
Go to the hospital next.
And always trust your gut feeling.
Okay.
So
if you feel something is not okay, then something is not okay. Better go check it.
Exactly.
Okay.
Don't postpone thinking that, okay, it will get better. Getting validation from someone around saying that it is gastritis. No, that is not the job. Go to a nearby physician. Just sort it out.
Okay. And when you say nearby physician, normally your way of procedure, first you'll do a ECG. Can you explain what does the ECG do? What does it show you?
See, ECG, basically what we are seeing in ECG is we are trying to do an electrical mapping of your heart. Okay. So we are, an ECG tells me three different things. Okay. I can see the rate, I can see the rhythm. If the rate is lower than 40 or more than 100 or 70, whatever the number is, I can identify it with that. Then the rhythm, if your heart is beating regularly, that I'll be able to identify. The more important thing for me, the third basic information for me here is if there is any STT changes that are there. These STT changes tell me if there is an acute heart attack or not. Okay. And 100% occlusion will definitely be picked up in an ECG. A massive heart attack will not get missed in ECG. What we say the overlapping symptoms, the troponin being done and other things are brought in is for these non-ST elevation myocardial infarctions. Okay. Where that means theoretically, there is no 100% occlusion in the vessel, or there was a 100% occlusion in the vessel which has suddenly opened up. In those places, it might be 70 or it might be 80, where troponin plays a huge role. Okay, for me to identify if it isn't there. The benefit here, what we are doing here is even we can revascularize the vessel in time so that your heart pumping capacity does not go away. So when you come with an atypical symptom, your troponin is elevated, there is some mild ECG changes, your echo function is normal. When the revascularization is done, one, your life is saved. Second, your long-term thing, your heart pumping capacity does not get any alteration or damages itself. Okay. And even in heart attacks, when people come, time plays a huge role and huge factor there. Okay. First 12 hours is called as golden window. Okay. Why? When a 100% occlusion happens, when a heart attack happens.
When you say occlusion, it's 100%
blockage. Yes. Okay. Happens. That particular territory is not getting blood. Every minute, every second we delay, the complications are going to be higher. The amount of muscle that I'm going to recover is going to get delayed. When I mean complications, what do I mean? The BP can go erratically low. That is called cardiogenic shock. That is the worst thing as a cardiologist I would want to happen in my patient. Okay. Then second, what can happen? Electrical disturbances can happen. The heartbeat can go erratically high or erratically low. Third thing, what it can happen? It can create a hole in the heart. Between two chambers, holes can form. Worst complication again. And heart itself can tear off. Okay. We call it as VSR. Okay. So these are all the worst complications that we see in patients when there is a delay in presentations.
So the golden is 12 hours. So immediately going really helps.
If you go in first 1 hour or 2 hours, as much as possible, the heart pumping can be recovered. The later you go, the later we intervene, the pumping, if you go at 40%, we will not be able to get it back to your routine 60 or 65%. And not only that particular territory which is not contracting, that particular area, the muscle is dead. That can become thinned, that can become scarred. If it becomes scarred from there, another electrical activity can start from there. That can cause a lot of problems in future.
Okay.
And you spoke about cardiac arrest. This pumping capacity, when it goes less than 35%, and after giving all drugs to you, after 40 to 50 days, or say after 90 days, if your pumping capacity is not recovered and it is still less than 35%, that person is at higher risk for cardiac arrest anytime. Then I'll have to put an in-house, like how we shock, you see in movies, we shock and they recover patients. You'll have to put an intracardiac defibrillator, something like a pacemaker device inside their heart that works as a defibrillator, watches out for electrical arrhythmias to give shocks. Okay. So
the golden hour is very important.
Very, 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 very important.
Can you also tell me a story where people came last minute? And
this is a very recent thing. Or a 62-year-old lady.
62-year-old lady, okay.
She had some she had for last 1 week to 10 days. It suddenly worsened from today morning. And she goes, she says to her daughter, I feel very uncomfortable right now. And they go immediately to a next door hospital. There they say, your thing looks very abnormal. You need to go to a higher center. We'll arrange an ambulance. We'll resuscitate you. They say, no. I want to go immediately. Took her in her own vehicle. Daughter's bringing her. She started losing consciousness on the way. Okay. Brought into the hospital in a gasping state. Okay. And cardiac arrest. BP is not recordable. She was not conscious. We did CPR. 6 cycles of CPR was done. We reverted her. Put her on a ventilator. I took her on for an emergency procedure. And one of the vessel was problem. Fixed that vessel. Patient's BP started improving. Over next 24 to 36 hours, her entire cardiac status is stable. Her whatever kidney injury was there, that recovered. Her liver injury was there, recovered. I've told you all the good parts. Right when we were resuscitating her, I had something in my mind because she was not a unconscious person who arrested in front of our eyes and we resuscitated her.
Which means you didn't see her when you went through. Correct.
Yes. Got it. The moment when she came itself, she was in an arrested state. The information we have is somewhere between 15-20 minutes back, she was in a nearby hospital where she was conscious. That is what the attendants say. But the time is 15 minutes. Okay. What happens is more than 9 minutes, if you're in an arrest state, your brain can go for permanent damage. Your brain does not get enough blood
supply.
Okay. So now we've reverted all those things. I've discharged that patient a day or 2 days back. She's gone for an hypoxemic encephalopathy. Her brain has gone for an hypoxemic encephalopathy. where brain did not get enough oxygen. The CPR should have been started earlier for her. We've saved her life. She's not technically brain dead. Her brainstem reflexes are all intact. But she's in a vegetative state.
Okay. So she's functioning, but
her organs are functioning. Her brain has gone for complete hypoxia.
So we don't know what will happen. We hope and pray that it recovers.
I don't think so. That is what the experts, neurologists say.
So what could have been done to save this? One is preventive, of course, we know. But once the pain comes, they should have come directly. You
should reach the right place. That is one. Or second thing, you should have allowed the other hospital to at least resuscitate you. Okay, you chose to go there, and this was told by the family only. They said they would resist. They did not.
What is resuscitate? Can you explain that?
See, they would have seen that her stats were not good. Maybe the BP was down there only. Maybe she was desaturating there. They would have probably put her on a ventilator there. They would have given her support to BP drugs and shifted with medical professionals from there. In case if she had gone for an arrest in between, they would have given her CPR and other things. So that would have, because the entire course is good now. It is not, we cannot say we don't know. The entire course is good now. We've saved her heart. We've got her lungs to do well. We've got her kidneys to flow well. Everything is normal.
But 15 minutes, that's where the problem is. Now you spoke about CPR. Why should everyone know how to do a CPR?
Because for this very same reason.
Yeah.
Something happens, you are shifting that person to an hospital, or you should ideally call for help. If somebody goes for unconscious, you should not lift in car and take them. You should start CPR and you should call for help. Allow the medical professionals to take it out from there.
So, Doc, one thing we should put on this podcast is everybody should learn how to do a CPR.
Exactly.
Everybody should learn how to do a CPR. It can save lives.
Yeah. And every corporate should have a program, or every organization should have a program where they bring medical professionals from outside. And there are a lot of, you can bring in those mannequins and you can actually teach people CPR. I mean, I have initiated a small program, and I've initiated in colleges right now. My principle in initiating in college is I teach one 18-year-old guy, 19-year-old guy. He at least does for 4 people at his home.
Yeah. So I'm going to tell in the description of this podcast how to do a CPR.
Yes.
I think everybody needs to really learn how to do it, because it can save lives actually.
People should get enrolled in this program. There is no need to incentivize you. You are saving lives. It might be somebody in your family. It might be a stranger. Somebody's life you are going to save if you know how to do a CPR rightly. Because it is not chumma going pressing the chest. You should know ideally how to give a CPR. So what you are trying to do is basically work how the heart is going to function, so that the blood is going to be distributed to the vital organs.
So basically, externally, we are doing the pumping of what a heart does.
Exactly.
So the blood starts going.
So basically, you are compressing the heart, so the blood in the left ventricle goes out, and then you are taking your hand back so that the blood comes back again to the left ventricle. Then again, you are compressing so that the blood goes back again.
So you need to know how to do it, the rhythm to do it, so that it's like external.
You'll have to do it in a proper rhythm. You'll have to allow the chest to recoil and then do the CPR again and again. So only hands-only CPR. You don't need to do mouth and all. Because for strangers, you don't know what disease they have, what other things. You can only learn hands-only CPR. But people should learn hands-only CPR. At least see people less than 40 years of age today. They should definitely learn.
And Doc, you tell me this first. So now, if I have a chest pain, if there's a block and the block is 70-80%, one of the symptoms will be chest pain?
See,
what are the symptoms?
Why do you get a chest pain?
Yeah.
Okay. This blood vessel is a tube. Okay. It has blood from A position. It is going to take to B. That is your heart muscle.
Correct.
In this flow, when there is a blockage, there should be a supply-demand mismatch that should happen here. The supply is the blood. Okay. Demand based on what your heart needs. So you're climbing a flight of stairs. Your leg needs more blood. Your heart needs to pump more. Rather than at rest, it needs to pump or do extra activity. That means your heart needs to pump more vigorously, or it needs to pump more number of times in a minute. Okay. When it does that, it needs more energy. Energy comes through blood. If there is a blockage, a significant blockage, that means that blood is not sufficient enough. Then whenever heart feels pain, you feel the pain. That is the chest pain.
Okay. So one of the things they could have got is a lot of breathlessness.
Yeah.
Because while climbing on the stairs, then the normal breathlessness, they might have more breathlessness because your heart is pumping more.
So what we generally tell patients is compare yourself with previous thing. Say 6 months back, I was able to do this particular activity without any symptoms. Now I am doing this activity and I am having symptoms. Then it becomes a very, very significant symptom to me. So then I'll need to rule out why it is happening. See, this blood vessel, I told you, the analogy, the clear-cut piece. It is 5% of your heart circulatory system. Your 95% of your heart circulatory system is microvascular vessels. Okay, when problems happen in microvascular vessels, that is what diabetes and all causes problem. That is what hypertension causes problem. These problems happen for a longer period of time. So when the problem happens in microvascular dysfunction itself, you will start developing these symptoms mildly. When you go there, we can start working on it. We can start preventing the disease that happens in the epicardial vessels. These are all the major vessels. In these major epicardial vessels only, we do this stenting, we do the ballooning, all these things can be done here. These are all your 3 mm, 4 mm, 5 mm vessels. Okay. These microvascular vessels are less than 1 mm vessels. Nothing can be done inside there. It will be like fibers of nets that are there. We can manage only with medicines in those scenarios. Even that can cause you symptoms. When the symptoms are in milder stages where you go for a consultation, you find out what is the underlying problem. And it all goes back to the basics. If you are a diabetic, keep your diabetes under control. Keep your HbA1c less than 6.5. If you are on hypertensive, keep your blood pressure under control. Bring it less than 130 in systole and 18 diastolic. If you are a dyslipidemic patient, you have a strong family history and you are diabetic, you need to keep it your LDL less than 70. You'll need to check your ApoB, you need to check your lipoprotein A. Lipoprotein A directly puts people at risk for heart disease. All these things needs to be checked constantly and routinely so that the disease that you develop in the epicardial vessels are reduced. And it not only helps for your heart, entire body has blood vessels.
Correct.
The same blood vessels in brain. If brain you develop a disease, blockage, it is stroke. In kidney, you develop a disease, you develop a renal artery stenosis, you develop BP more, you develop, your kidneys gets damaged. Same thing happens for your legs. When your leg blood vessels gets blocked, you start getting pain, then you start losing your fingers, you start losing your leg itself. So these blocks, they don't happen only in heart vessels selectively. They can happen in all blood vessels that are there in your body.
Okay. So it's not only heart there alone.
Exactly. Okay. So when you're treating the heart blood vessels, I'm treating everything. You can even have a problem with the erection also.
Okay.
Everywhere there,
because that's also blood
vessel.
Blood pumping. Okay, now let's talk about this. So I have a symptom or I have a chest pain, little breathless. I come here. You tell me what is the diagnosis? How do you go about it?
See, all breathlessness are not cardiac.
Correct.
But a cardiac condition needs to be ruled out when you have a breathlessness. So this is a job of a physician which happens in a one-on-one consultation. You try to differentiate what problems it can be because of lungs. A single anemia can cause breathlessness.
Correct.
Okay. Your HB being less than 10, less than 9, that can cause breathlessness. Okay. The cause of breathlessness is wide. That is a job of a physician. Okay. Yeah. What happens is in this AI era, everybody wants to diagnose, everybody wants my job. Okay. No,
so
it is not possible.
Everybody goes at ChatGPT saying breathlessness, 45-year-old, this happened.
I did 15 years of education to sit here. Okay. I will only do the job.
Don't go to ChatGPT.
Yes. See, it is not ChatGPT. It is a validation that you want. You want to diagnose yourself. I diagnose this right. I want to do it. See, it is not fun. Okay. When something goes right, it is okay. When something goes wrong, it goes terribly very wrong. Okay.
Yeah.
It is a job of a physician to find out what is your problem. A breathlessness cannot be only because of heart. I said it can be a systemic problem. It can be a problem that is related to your lung. It can be a problem that is related to your heart. Okay. And physician is the right person to diagnose what it is. And he says, okay, boss, it looks cardiac to me. You go see a cardiologist. Then a cardiologist sees and finds out what the problem is.
Okay, now tell me this, doc. Okay, somebody comes to you with pain, you're ruling out, and how do you know it's a block? You said the troponin test you do, then then what is the procedure you do?
Okay, so how can we identify where the blockage is and how much the block is? Coronary angiogram is the test we do to identify these things. An angiogram is nothing but a diagnostic test. It is not a treatment. It will tell you where the block is, how much the block is. It is a procedure we do through your hand or through your legs. 99.9% is through the hands. Okay, we put in sheath, we take a catheter to the heart. Like I said, out of the left ventricle above the aorta, you have two main blood vessels which gives two branches here. You engage those vessels, you give dye. You replace the blood with the dye and you shoot an image in X-ray as in video. Okay, and you see it in 3-4 angles. The reason is it is a 2-dimensional image. You want different angles to see how the blood vessels are there. Okay, and it is a tube that runs around. A dye is filling it up. If there is a blockage, it gets narrowed in between and then again it widens back. With that, we identify with the distal segment as a reference range. We identify how much blockage is there.
Okay, I'm going to pause you so that I understand as a layman what you said.
Yeah,
you're saying a coronary angio is you're going to take them for a procedure. You use and put the, what do you call it here?
It isn't sheath.
Sheath.
You
call
put
it
in the radial artery.
Radial artery. There's a radial artery which goes to the heart here. So you put that and then you're going to put a dye and based on the dye image, you'll know if there's a block, you will see the dye thin down and go out.
Yes.
That tells you the block.
Yes.
And that tells you the percentage of the block.
Yeah. Editor put a nice image.
Okay. We'll try to put an image. Team put an image. Okay. Okay. So we'll get to see that.
Okay.
Then what happens while you're doing the coronary?
So once we have done that, we are diagnosed. Say for example, in ECG, I saw that person had an anterior wall MI. I will know LAD is going to be the culprit here. Okay. So we have injected and dye. We have found out that LAD has the problem.
What is LED?
So when I said 3 different vessels, each has a name. Okay. The left main trunk that originates is called LMCA. Okay. Left main coronary artery. Okay. It's left main coronary artery. Okay. From there, 2 branches are coming. The upward branch is called LAD, left anterior descending artery. The downward branch is called LCX, left circumflex artery. This is what is generally there for normal people, normally for everyone. Some people might have a 3rd branch there. It is called ramus intermedius. Okay. Similarly, right side, it is right coronary artery. It is a very simple.
This is the major vessel which puts blood to the heart?
Yes.
Okay.
This left side system, predominantly it is 70% from left system and 30% from right system. For some of them, it is left side itself is 90% and right side is only 10%. Okay. Now, when I meant this LAD, it's called widowmaker artery.
Okay. As the name says, explain that.
Yeah, it's a widowmaker artery. When people have blockage in this vessel, previously people used to die. Okay, so you should understand the evolution of the disease itself. Not until in 90s we had something or late 80s and 90s, no angioplasty was there. Before then, angiogram would be done. People would go for only bypass. Okay, so what was angioplasty? So we did an angiogram. We crossed a wire across. We thought we will balloon it and open it up. Simple plumbing. Okay. There is a blockage in this tube. Let me put a wire. Let us put a balloon. Let's open this. Okay. Now flow has come. This guy should be okay. Surprisingly, 30 days, 1 month, 2 months, 3 months back, people are coming back because that particular area got recoiled. Okay. Then they said we need to put a scaffold to this so that it does not recoil. We put a scaffold. That was the era of bare metal stents. People were again coming back in 1 year or 2 years because there was new blockages inside. Then we understood that means we'll need to have a drug inside this. We'll need to put a polymer inside it so that the drug delivers over a period of time. Now that drug delivery mechanism, which was there for 1 year, cut down to 6 months. Now it has cut down to 1 month where the drug delivery happens, and the evolution has happened in last 2 decades to extremes that we know precisely what can happen in this particular stents in this. Okay. So now what we do is we go there as the evolution. We dilate, we open the vessel to the normal size. Then we go put a stent there and we come out. Okay.
Stent is basically, can you explain what a stent is?
A stent is a metal mesh. It acts like a scaffold so that your vessel does not recoil. It also has a drug in it. The newer generation stents, they have a drug in it. They have a polymer. There are certain polymer-free stents also. There is a drug in it, which is slowly released over a period of time. Different company stents release different over a period of time. Roughly about 30 to 60 days it gets released.
So how a stent, if somebody puts at 70%, whatever block, how long is the validity of the stent?
Stent is going to be there for lifelong.
Life. So that vessel, he's pretty safe for some time. How long is he safe?
How long he is safe is depending on you.
Which means the lifestyle, what he does after that.
And the drugs that you're going to take. Okay. And there are very, very few miniature complications that can happen for very random. I don't think we should stress up on that and people should get worried about it. But in principle, that particular territory, we take medicines, it should be fine. We call something called TLR, okay, target lesion revascularization. Okay, that can happen about 5 to 7% depending on it. And it also depends on the patient's anatomy per se. Okay, if that doesn't see, I'll tell you one analogy. Putting stent is like putting a road. Okay, in Chennai, you give me a road contract to put an road.
Okay,
it's a plain smooth surface. I clear off the debris, or there is an existing road, I clean it off, and I'm going to put in road as per your specification. Now you give me a job to put it in Kodaikanal, or you say you go put it in Himalayas, where there is no passage or pathway at all. Now, in a heart attack, when the time is very, 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 very crucial there, it's a calcified place. It is I'll need to break hard those stones, which will take me longer time. Those are all the places where we anticipate more things. Not only in heart attack, even in elective patients, when you break those calciums, you'll need to break those calciums effectively so that you put on a good road there. Okay. So that happens when there is calcifications or when there are other parameters, then the target lesion revascularization percentages goes a little higher. When the stent is not expanded well, when the stent is not in a right position or it is not placed, the percentage of revascularization rates were higher. But now with advanced imaging, say like we use an intravascular ultrasound, say with OCT, the era of the terminology is instant restenosis. The era of instant restenosis have drastically come down.
Okay. Now you said about calcification, plaque formation. Can you explain what it is?
Okay.
So that we understand as laymen, what are you talking about? What is that block?
Okay. See, once we talk about blockages, it is a very simple concept that people think blockages happen over a period of time. It happens inside the lumen of the vessel. Are you guys able to see this? Okay. Inside the lumen, this is the vessel. This is the lumen of the vessel. Inside the lumen of the vessel, the plaque happens. It's not that simple. Okay. So a vessel has 3 layers. It's called intima, media, adventitia. Okay. Now, when your LDL cholesterol is high for someone, lipoprotein A is high, apolipoprotein B is high. Okay. The vessel layer first breaks. The LDL that gets accumulated not in the lumen of the vessel. It actually accumulates in the vessel wall. It gets accumulated.
Okay.
There the plaque formation, there the inflammatory signal pathway gets activated. The plaque formation happens here. Okay. Now, when you say young people who develop sudden heart attacks, they will have good lumen also. They can have good lumen or only 5% disease here. Now, this plaque that was forming inside here has a huge core that gets ruptured, and suddenly this particle comes fill this particular lumen 100% blockage. So your heart does not know how to react because it was not trained for 20%, 30%, 40%, 50%, 60, 70, 80 into supply demand mismatch. It was never trained. It is like a spoiled child. Okay. Suddenly, all these days, all allowances were given. Today, everything is cut off in 1 point of second, and that is when this massive, the more of cardiac arrest happens in these kind of physiologies only. You will have worsened complications.
These are the people who actually die because the heart doesn't know what to do. So you're saying because the plaque is outside, though the block is only 5% technically, no symptoms would have come. Yes. It ruptures and it completely blocks.
So this is what is a heart attack. So the differentiation between a block and an attack, a block is like, okay, let us put it this way. A block is something like 100 is the maximum. A block is something like you add money to your savings account every day, every month, as you live, as you age. Okay.
It is going to happen.
Yes. You are adding in your savings account. You are adding 5, 10, 5, 10, 1, 2, 3. An attack is not like, it's like a lottery. 100 rupees falls in your account today.
Okay. That's the difference.
Yes.
So normally if the block is slowly increasing, you'll get some symptoms.
Yes.
Here you won't get because suddenly
it happens. So this is what when I meant, going back to the initial conversation, a block is where you can get symptoms, where an effort angina can happen. And people can come with symptoms. We can do investigations. We can fix even date for angiograms. People choose auspicious dates here also.
Okay.
Fix a date for an angiogram and get. But an attack, when you get lottery, no choosing date and time and all. We'll have to sort it out immediately.
So now tell me the other thing, doctor. So for people who are watching this podcast, what is the preventive thing they have to do? Now you're saying that you won't even know this has happened, right? So what should we do? Is there any test regularly we have to do, or what should we do?
See, start screening as early as possible. I would say 18 years of age. Forget about other screenings. I'm telling about atherosclerosis screening. See, so far, whatever blocks, attacks we are talking is all because of something called atherosclerosis. Okay, this is the basic, it's a chronic inflammation that happens in our body. That is what is causing all these things. Start screening as early as 18 years of age. What are the things that can cause this? Something like diabetes can cause. Something like hypertension can cause. Something like dyslipidemia can cause. I'll tell you certain data. Okay, ICMR DIAB study. A very good study that has come out recently. How many people what is the percentage of people who will have diabetes in India? Can you put me a rough number?
1 in 4, I think.
Okay. 10% is what is the ICMR DIABs. Okay.
So 1 in 10.
Okay. How many people will have hypertension?
I have no idea. Now you tell me.
35%.
Hypertension is more than diabetes.
Okay. How many people have dyslipidemia?
No idea.
75% have dyslipidemia.
What is dyslipidemia? Can you please explain
dyslipidemia is 4 parameters in your cholesterol. When your HDL is low, or when your triglycerides is high, or when your LDL is high. These are all the things. If any one of things is abnormal, we call it as dyslipidemia. Okay. So people with low HDL is maximum in our country. Closer to staggering 70% of the people had low HDL. Okay, which is supposed to be your protective good cholesterol.
Yeah.
Okay. So, and triglycerides is basically it is secondary to insulin resistance. Generally, triglycerides is something secondary to your body. Some other thing in your body has increased triglycerides, or it can be familial. Okay. So, what is that other cause that is causing your elevated triglycerides? You'll need to identify and treat it. Okay. And third is your LDL. No diet will help. Okay. LDL is elevated. It's your genetic gift. Okay.
I want to pause here, doctor. So HDL, which is your good cholesterol, according to recent study, 70% it's less.
It's low. Most 70% of the Indians have low HDL.
Which is good cholesterol.
Yes.
Good one.
Good one.
Okay. LDL, what you're saying is something, it's not because of lifestyle or food. It is what your fathers, forefathers, grandfathers gave it to you through your genes.
Yes. To most. When you cut saturated fat, you can reduce about 5 to 10% in max is what you can reduce in your LDL. Nothing above you can do.
This is what we call bad cholesterol.
Bad cholesterol.
Okay. Now, what is the difference between fat and cholesterol? First, tell me that so that I'll understand that.
Okay. See, now you mean to say good fats and bad fats?
Yeah, better.
Okay. So, see, what people call it as good fats and bad fats is saturated fat, good fats is unsaturated fat. Okay. For very easy understanding is your omega-3s, your is all good cholesterol. Your avocados and all come under good cholesterol, whichever has high MUFA content or high PUFA content alone comes here. Whichever has very high saturated fat, something like ghee, something like red meat, something like hydrogenated foods, which and all will come under trans fats and unsaturated fats comes under your bad fats.
Okay. That's the bad fat and good fat. Okay. Now let's go back to your study you spoke about. 10% is diabetes, 35% is hypertension, 70% is your low HDL, which is your good.
Yes.
Okay. Now that's a study for Indians now. Yes. Now tell me what should we do? What test we should do?
So now the point is first stop saying that everything is normal to you. Okay. When you have symptoms, that means you have a disease. Okay. As we grow in our economy, non-communicable diseases will start growing. The diseases of rich will start coming. Okay. Whatever Western people have diseases, those diseases will start coming to us and we'll have to be prepared for it.
It's already started, no, doctor?
Yes, it is already started. We have to be prepared for it. Now, the point is you'll have to start screening at 18 years of age if you have diabetes, if you have hypertension, if you have dyslipidemia. Everything is normal. Congratulations, come back next year. Okay. So, but you will have to do it constantly.
Every year, make it a point to do these tests.
Yes. And a lipoprotein A is a test. You do it once in your lifetimes as of now to determine what is your risk. Okay, if lipoprotein values are more than 100, okay, and it varies among units also. When it is greater than more than 100, when it is less than 20, you're good. Okay, 20 to 50 is borderline, 50 to 100 is slightly riskier, more than 100 is a very high risk parameter. These people tend to have diseases slightly earlier also. Okay, even if your LDL is normal, you'll need to do something called ApoB in all these individuals. Okay, so these are all the certain things that you need to. Apart from this, most important parameter is a family history of heart attack or stroke that has happened in your first family. That is your siblings or your parents. Less than 55 years in male, less than 65 years in female. If somebody has got any one of the ASCVD, that means they could have had a mild heart attack, they could have had a stent, they could have had a bypass, they could have had a stroke, any blood vessel related atherosclerotic problem that they have. That means you have a higher risk of developing it, and you need to be screening more cautiously. Okay, so these are the parameters that needs to be done. And after this, my advice is you don't screen at home. My advice is go to a physician, get screened by them, and they will decide what higher investigations you need to do. Somebody needs to get a coronary artery calcium score, or somebody needs to get a CT angiogram. That is a job of a physician to decide what investigation needs to be done. But I don't think we should be educating public about it.
Okay, so to start with, your diabetes, blood sugar, and you're also saying lipoproteinemia at least once.
Yes, once in a lifetime you'll need to do it.
Lipoproteinemia.
Yeah,
okay.
100%.
So that's one of the things. Now tell me, one of the things which I heard is women don't have heart-related problems when they're 45, 50. Is it true?
See, it's a simple thing is their protection from their menstrual cycle. So once, let us put it in this way. Till they attain menopause and the age group, say it is 45 to 50 years. Till then, men are at more risk compared to women. Okay. Post menopause, in that age group, women are at have higher incidence compared to men. That is the difference. The more important point is women have worse mortality compared to men. Okay. The reason being is women don't present early with symptoms. Okay. They generally drag it till the end.
Which means they don't take the symptoms seriously?
Yes.
So that's why the mortality of women is more than
slightly
men.
more.
Slightly more than men.
Yeah.
Okay, because they don't take it seriously.
Yeah.
Now tell me this, doctor. So now we are talking about this. Can you tell me what is bypass then? You're saying if there's a block, you can do a stent, right? Okay. Now then what is bypass?
See, I said 3 vessels are there. Okay. Now there are data for certain things. When there is the evolution of our intervention itself started with bypass. Bypass started happening. Then we started doing intervention. Then we are doing step by step single vessel, multi-vessel PCS is what we are doing. We have data when the patient has multi-vessel disease. Say if the patient has left main, the patient has disease. Patient has an LAD, LCX and RCA. All 3 vessels needs to be revascularized. Both stenting and bypass is a form of revascularization, and basically your muscle gets the blood. Okay, so first, what is bypass? Bypass is, say if the lesion is there in the midpoint of that LAD. Okay, I am going to take one new vessel. Okay, might be from your leg, or there is an left internal mammary artery which is connected to your subclavian artery. You take that artery and you cross that lesion and you graft it. Okay, one more analogy. So we are sitting. I'm from Sriperumbudur. Okay, so there is a Sriperumbudur town that is there. You want to go to Bangalore, from Chennai to Bangalore. Previously, people used to come inside my town and come out of my town to go to that place. The place got big. There were too many vehicles. There was too much traffic congestion. So what did the government decide to do? It decided to put an outside bypass road so that you don't come inside the Sriperumbudur and go. Okay. So the Plaque was basically Sriperumbudur. So the new bypass, what we are doing is the Chennai road is directly connected to the across the Sriperumbudur. You're joining this road so that the traffic is avoided. Similarly, after coming out of left ventricle in your aorta, the first vessels that comes is your coronary vessels. Now you get a new vein from your leg. You suture one end to the aorta, the other end you suture across the after the lesion, so that the lesion is bypassed, the blood goes distal to the region. Okay. So depending on your block and your severity, and heart team sits and decides this patient will get better with stent, this patient will get better with bypass. A conversation me and surgeon has, whichever is better for patient, whichever is best for patient, we decide. Because we cannot decide on a single basis saying, okay, this is how it is there, it is angioplasty is stenting. If this is how it is there, we'll need to bypass. It is a conversation happens for each and every individual, and the heart team takes a final choice, what is the best option for the patient. Predominantly what happens is patient comes back saying, see, I don't want this procedure, I will get this done. And then with the consent of the patient, sometimes either of those things have been done.
So based on what the patient problem is, you take a calculated call seeing all the symptoms, what it is, whether you have to do a bypass or
yeah, there are certain scoring systems for us to determine if the patient will get better with bypass or with the stent, and the heart team we discuss and we take a call.
Because bypass, the post-op is little more longer. Stent is much more easier, right?
See, but that is one. Okay, that is how patient sees.
Correct.
That is how patient comes back to us and saying, sir, I don't want this. Get me this done. But as a heart team, I'll need to tell him what is going to be better for him. As an cardiologist, I need to tell him, see, this is what is going to be right for you at this point of time. And with a cardiothoracic surgeon. A cardiothoracic surgeon is the one who does the bypass. Both of us sit, both of us presents the fact to the patient, and ultimately the patient has to make a choice what procedure they have to get it done. But we would give our choice, this is what you'll need to get it done.
Okay, got it. So doctor, you've seen a lot of patients. I don't know the number count you have or not.
Yeah.
What are you seeing now? Generally people walk in. What is the normal problem people walk in? And are people aware and they come early at the symptom stage or preventive stage, or only when a problem comes, people are coming?
It is mixed. Okay. I would say the awareness has got better. People in 20s and early 30s are aware. People in today's maybe late 30s and 40s are very, very, very negligent about their health.
So you're saying the Gen Z are 20s are more aware.
Yeah.
They're reading social media. They understand the symptoms and they come.
Yeah.
Preventive also?
Yeah. They come sit. I mean, there's one guy who's been haunting me from Bangalore. He comes every 3 weeks saying that I have this, I am doing this follow-up. You told me to do this. I just wanted to update you.
Wow. Okay, such people also are there.
Yes.
Okay.
He's 22 years old.
Okay.
I said, you have nothing to worry. He's got everything cleared. He's saying, no, I just wanted to, I wanted to drop in. I wanted to say everything is fine.
Okay. So that is also there. So all kinds of people are coming, but you're saying the 30, 40s are negligent.
Yeah. They don't take preventive seriously. They are not taking very seriously.
Okay. I want to ask you this. My team gave me this tofu.
Mm-hmm.
Thin outside, fat inside. Some people think thin people are very healthy. They'll never get a cardiac problem. Is that a myth?
This again goes with, people with if somebody with a familial hypercholesterolemia, that is, their family had a strong history. That person's LDL is already more than 180, and LDL has nothing to what you eat at all. Okay, so that means
LDL is your bad
guy. Mm-hmm. Okay. So that means that person is already at higher risk of an ASCVD event. It does not matter he is thin. That does not matter he is obese. He has an higher risk of developing this problem. For the longer the duration, his blood was exposed to higher LDL. So the best thing and better thing for him to be done is to get it as low as possible. I'll tell you more. This familial hypercholesterolemia is not as rare as we think. Okay, it is quite there. 1 in 350 people has it.
Oh.
Okay, so the problem here is people with more than 250 or 300 or people with more than 400 who are in homozygous category, they will have heart attacks in 20s.
Oh,
this LDL being that much very high. Okay, so thick and thin has nothing to do with that at all.
Okay, nothing. So it's better to do a test to see where your LDL is. If LDL is high, then you have to be more cautious.
Yes, exactly. The reason why I said I want screening at 18 years of age, my interest in lipids is high. I want everybody who enters a college should be screened for lipids. Anybody whose family history, they have an heart attack or stent or stroke that has been there, they should be screened at least at 10 years of age. So that we'll know how much LDL is there, and we'll need to watch those kids from there on so that we can start treating them as early as possible.
So doctor, with this podcast, we want to get the awareness going that don't wait for a problem or a symptom.
Exactly.
you need to get started early. Just check.
See,
so that you're aware.
Fever is when you have a problem, you go to a doctor, take medicine. You want to prevent non-communicable disease. See, basically non-communicable disease is you don't get disease from another person. It is a disease that happens predominantly because of your lifestyle or your lifelong. The longer you live, you develop certain problems. Okay, so these problems, you will need to identify what is the precursor for it, and you'll need to start treating them. Today's infrastructure, today's tech, what we have, I don't think we should be living familial hypercholesterolemia, diagnosing them at 40 years at heart attack and all should not be done. It should be identified earlier.
So to everybody watching the podcast, we need to tell them, please do your tests, understand where you are.
Yes.
If you're good for you.
Yeah.
But do a yearly once and just keep
If
keep
you're
the
good,
check.
congratulations. Come next year.
Happy for you. That's all. Come next year.
Yeah.
But make it once a year.
Yes.
Okay, doctor. Also tell me this. How much does stress play a role for heart-related problems?
See, stress is inflammation. Okay, you are in constant stress. Your stress hormones are going to be high. If your stress hormones are going to be high, your catecholamic surge is going to be high. If that is going to be high, the entire inflammatory cascade pathway is going to work. Your heart is going to be overdone. That is the worst thing you can do for your body. Stress and lack of sleep, and the lack of sleep also indirectly causes again stress only.
So I want to ask about sleep. So sleep also is very, very important. So for people watching this, which are the 4-5 lifestyle changes you would suggest that irrespective for you want to take care of your heart, what should they do?
Sleep 7 to 8 hours.
Okay.
That is one. Move. At least do physical activity at least 5 days a week. Try to do at least 45 minutes per day. Okay. Try to add not only cardiac activity, also try to add some resistance based exercise also. People with low HDL, we said 70% problem. No, physical activity is the only thing that can improve your HDL. No drugs can improve your HDL.
Okay, it's not the diet also, it's only physical activity.
Only physical activity can improve your HDL.
So if I want to improve my good cholesterol, I have to improve my physical activity.
And do a lot of legs.
Okay.
There is data for quads, good amount of leg exercise and HDL going up.
So when you say we should do more cardio and do a little weights also, what would you suggest?
So see, the problem is for two things. People are not touching weights, especially I said this, people who are in late 30s and those are in that 40s group, no, they don't want to touch, they are predominantly into, even if they say exercise, they'll say only, sir, I'm doing walking, sir.
Walking, yeah.
Okay, this extends to this 50s category also. What they say, sir, I'm doing walking, sir. They will not do any other strength building exercises at all. See, as you age, see, we are sitting in this building. What is the load bearing for this building? Whatever the basement that you have put down. Okay. Similarly, your muscles are the weight bearing things that is very, very required for you as you age and as you do all your things. So you'll need to constantly work on your muscles for your resistance training so that your muscles are also strong. Along with that, you'll need to do good amount of your cardiac activity also to stay particularly fit for yourself.
So the balance is important.
Yes.
So it's not only cardio and a little resistance training also so that you take care of your muscle.
Yes.
So you said sleep 7 to 8 hours.
Okay.
You said 5 days a week, at least some physical activity.
Yes.
Now, can you talk a little about food?
Food.
What is good for heart? What does the heart love? And what does the heart doesn't love or hate?
All your blood vessels. Okay. I think people should consume good amount of protein. Okay. 0.8 to 1 gram per kg body weight. Okay. Good amount of fiber. 25 grams of fiber per day. Carbs as much as you can cut down. Try to restrict carbs. And fats, I would say avoid saturated fat wherever possible.
Okay, so this is a good plan to start with to look at. But vegetarian people don't eat a lot of meat, so they say they don't have cardiac problems. Is that true or doesn't really make a difference? Veg, non-veg?
They eat vada.
Oh, okay. So again, you're fat.
I wouldn't say that way. No.
Okay, it doesn't make a difference between veg and non-veg. Okay, we love to go to movies. Let's say PVR, we take one big bowl of popcorn. Can you tell me how good or bad that is?
Obviously, you will add all possible things to it. You will add, what do you add in popcorn? I've not had for long.
You don't have. Okay, they add a lot of masala in PVR. They add a lot of masala, butter, and all that.
Okay. I think no. You should. I think water. You can take water from outside now I think you should take water from home, go drink inside and come
See
out.
the movie, drink water and come back. Avoid that popcorn, tub of popcorn.
So you can save, your wallet is also saved.
Yeah, correct. Okay, now what are the good foods for heart? I know that beetroot is good for heart. Pomegranate is good for heart. Any other good food for heart?
Have good amount of guava.
Okay.
So when you say food, first thing that comes to me, see, it is about, it has good amount of fiber. Pomegranate is my personal favorite. I would say have all veggies possible unless or until you're contraindicated. Certain valvular conditions, when you're on certain drugs, there are certain things that are contraindicated. But otherwise, I think you should have whole lot of vegetables. I would say this as in food. People, how much they consume rice, okay? They should consume fiber. They should consume the vegetables. And how much ever portion they're consuming the vegetables in that small cup, in that consume your rice.
Okay, if they can swap both.
Yes. It doesn't matter what rice and all, okay? Have any rice you want. It doesn't make a huge difference. But consume good amount of fiber. The fiber that we consume is what is going to help you in long term.
Okay, so that will be a good balanced meal to start. Reduce the rice, take more vegetables because you need fiber there. Okay, doctor, now tell me, for people watching this, when we got them scared that it can happen at 80, 20, 20, 25, 30, really doesn't matter. Because of late, we're seeing a lot of, even Punit Rajkumar. He was gymming, very fit actor, and he died of a sudden cardiac arrest, right?
See, we don't know his LDL, we don't know his lipoprotein, what has happened to him. We don't know if he has hypertension or not. We don't know if he had diabetes or not. Okay. See, one thing I would say is, you would see this trend post 2016 very high. That too in COVID, it has drastically gone high. Thanks to Jio and its penetration, internet all across the country, and CCTV penetration, we are able to get a lot of images what is happening, and it is getting circulated in social media.
So you're saying it used to happen before also, but now people are scared because you're getting those
videos.
Getting
more, yeah. So sir, our interaction with social media has gone up drastically high. The penetration of internet has also gone drastically high, so that you're getting information all across. Not, I've seen one dancer somewhere in Madhya Pradesh, she was doing a small stage show and she collapsed and fell down. And I'm saying, see, it is not only heart attack. Unless or until you do a postmortem, you will not know what was the actual cause. There are other different causes of cardiac arrest that can happen also. And there are even non-cardiac reasons, but they will generally have some symptoms. They'll have a course and other things. But we'll need to identify what is the cause actually.
Okay, doctor, to sum it up, if somebody watching this podcast, one, don't wait for a symptom, just go check. Step number one. Correct. Do a little lifestyle changes where sleep properly, avoid stress, eat a balanced meal, 25 grams. Anything else would you suggest to take care of the heart?
Don't smoke.
Okay. How bad is smoke? Just tell me that for people.
Smoking is one of the worst cause that can cause heart disease. And if you're somebody who's smoking, if you quit smoking, you would be as equivalent as a smoker in a couple of years. Not smoker in a couple of years.
Okay. So which means you stop smoking.
Yes.
Alcohol. Some people say have red wine so that your heart is good.
No amount of alcohol is safe. There's no data.
There's no data. No red wine, no nothing.
Nothing.
How does alcohol affect?
See, alcohol again, two things it does. One, it spoils your brain. Second, it spoils your liver. Third thing, it adds up to your insulin resistance. You take a lot of empty calories along with it. And short binge of alcohol. See, alcohol has two sets of problems. Okay. One is acute problem, one is chronic problem. Acute problem in heart, what I get is, when somebody binge drinks, they can have something called holiday heart syndrome. They'll have rhythm disturbance in the heart, and they come to an emergency department, and that needs to be sorted, and that can sometimes land up to a stroke also. Okay.
That's like people having shots non-stop.
Binge drinking. You don't drink for a long period of time and you suddenly drink more amount of alcohol. That is one. Okay. And second thing is, long-term problem with chronic alcohol consumption is, one, it can cause something called cardiomyopathy. Your heart can dilate and it can cause problem. And second thing is, it also worsens the coronary artery disease. It goes into that metabolic pathway. People end up in insulin resistance and they develop ACVD diseases.
Doc, you're very, very active in social media.
Okay.
You have tons of followers, lakhs of followers. How did that happen? So,
social media, it's very accidental. My wife was actually very active on social media. This boiled down to one particular patient, one particular incident that said, okay, I'll need to come out, talk in social media, create some awareness. Okay. ஒரு பேக் ஸ்டோரி. ரைட் ஃப்ரம் மை MBBS days, my favorite subject itself was community medicine. Okay, community medicine is reaching out to people, interacting with people, talking with people. I love to do that. I love to hear their stories, and put a thought. If I have a thought there, I would always share my thought also there. Okay, now this one particular patient who's very well educated, in his early 40s, he was working in a very good MNC in a very good position, had a very good insurance also, somewhere about 25-30 lakhs rupees insurance coverage. Okay, on that particular night I was on duty, on call in my hospital. This guy around 12:30, he had some discomfort. He came down from his apartment, took a car, went to a nearby clinic, a clinic come hospital somewhere. He's gone there. They'd seen him. He has told his symptoms. They'd given him some medications. He thought it is gastritis and something like that. Don't know if ECG was advised, declined, no idea about what was happened. But he had some prescription for some medications. Went home, watched something, some TV, something for some time. He thought he felt better. He went, slept. Morning 6:37, father brings him. Sir, பையன் எந்திரிக்க மாட்டேங்கிறான்.
He's not able to wake him up. Okay.
He's not able to wake him up. He's brought him. He was brought in cardiac arrest state. Okay, we were not able to revert him. Unfortunately, this entire incident was explained by his father, a guy who had everything there. The hospital where I was sitting there was just 2.5 kilometers away from his home. He had come somewhere very close proximity, and he had gone back. I ultimately thought he didn't have the right awareness to go where he needed to go at that point of time. Somebody who had an information that this atypical symptoms could be an heart attack, had he gone to an right place, he would have been saved.
So you actually went to a small clinic?
It isn't or 24 hours, somewhere he had gone there. He had taken a gastric, the slip that the father bought me, because we don't know the story. He was not there to tell the story.
Correct. So we don't know what happened. So they must have seen a slip and okay. So 6:30 they bought in, but it was too late.
Nothing.
So you after that you felt that people need.
That particular evening I came back and said, I'm going to create awareness. I want to talk. I don't know how many people are going to listen, but I'm going to talk. I'm going to constantly create awareness. If you look at my page, I'd be talking about some common things what people will want. But I'm increasing that percentage now. It was 50% more. Now more than 50% is technical content now. Now I want people to have clear-cut awareness, and I'm very happy with the impact it has created. A doctor from down south called me and said, sir, I did this one patient. He had some calcium. I wanted an OCT. I was counseling the patient. The patient said, I had seen Dr. Arvind's video. He had spoken about OCT. I understand there is an calcium. You can go ahead and do it. So I'm treating the impact of that is even in patients whom I'm not treating. The information is reaching, and they're taking up awareness. So
thank you, doctor, for doing what you do, because I've seen your Instagram, I've seen your reels. The information you give is very, very critical. It can save people's life. So I know it takes a lot of your time. It's not easy to go on social media and create those reels, but thank you for doing that. I learned so much from this conversation. I think it's been deeply informative. For everyone watching and listening to this, I think they kind of know what they need to do. One, do regular tests, do the lifestyle changes. I think first the regular test is the most important thing. Don't wait for a problem to come. So they start doing that. So big thank you for that. We have a tradition in a Greater Than podcast. Okay. We have something called 3-2-1. You don't know what is 3-2-1. So I'm going to ask 3 books you would recommend to people watching this.
Okay. 3 books. Non-medical.
Okay, non-medical. Yeah. You tell medical, we won't understand technically anyway. So give me non-medical.
So Sapiens, something I love.
Yeah. Homo sapiens.
Homo sapiens.
Yeah.
Then Atomic Habits.
James Clear, brilliant book, Atomic Habits. Yep.
And third, I'm reading a book, my current read, Psycho-Cybernetics. Okay, the other two I've read, this I've not read, I'm going to catch it up. Okay. I'll send you.
Okay, now 3 is done. 2 value system which has helped you reach here.
Discipline.
Okay.
Integrity.
Brilliant. Okay, now one person you're very grateful for.
My dad.
Okay. Is he there?
Yes.
Okay. Is he also doctor?
No, not doctor.
No doctor.
But he always wanted me to be a doctor. He pushed me to do super specialty. I was content with internal medicine.
Okay. So you're the first doctor in the family? Thank you for doing what you're doing, Dr. Aravind. Okay, the second tradition, which is the final thing, your greater than message for the people watching or listening to this podcast.
Learn CPR.
Okay, one line. I think that's a very, very ideal message.
Learn CPR because it is the intention to learn CPR and to do CPR for somebody to whom to do CPR. And if you do it at the right time, I mean, like I said in the story, you will be saving someone's life. That person would be walking today. That person would be doing all kind of things today.
Thank you, Aravind. I had a lovely, lovely conversation. Thank you for coming in Greater Than Podcast. Thank you for staying till the end. This podcast is about helping you shift perspectives, push your limits, and take steps that actually move you forward. Just remember that you're greater than anything life throws at you. I am Surendran Jayshekhar signing off. We'll see you again next Friday at 8 p.m. Until then, love yourself. Don't take life too seriously. Live a life of meaning and purpose.